A very good evening and warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the National Neonatology Forum. And the focus of today's session is the NNF Shine Week 1 North Zone. So without any further delay, let's begin today's session, for which I would like to invite Dr. Prakhar Devata sir to take over. Over to you, sir.
He is Dr. Pradeep Devata. He is डॉक्टर देवता अपना नाम भी थोड़ा करेक्ट कर लीजिएगा हाँ ठीक है वहाँ पे
Okay, I'm so sorry for the mistake.
Actually,
there's his son's name.
It's my son's name and it is his laptop. So I'm Dr. Pradeep Devata, and today's evening session I'll be taking just now. This is the basic newborn care, and just to sensitize you all about the newborn, how we do care a normal newborn, particularly in normal adult, you don't need to any care. He can take care of himself. But even though the newborn is a normal newborn, you have to give some care so that they can thrive and they can survive and thrive. Okay. So today we'll be talking about the normal newborn care. So let's start with the quiz. Why this we are talking about normal newborn? See this picture and can you identify all the what is there in this newborn? If you see it first, then you must be thinking something pathological. Serious erythematous and little bit of papular lesion over back and trunk, okay, and quite red, and in some part you can see the papule and looks like somewhere pustules type also, okay. And so, but this is not a pathological condition at all. This is erythema neonatorum, and these are particularly erythematous rashes with central pallor appearing on day 2 to day 3 of life in term neonates, and it's quite common, okay. And it can present on face or trunk or extremities anywhere of the body. And if you ask me the cause, it is not known, and it's the disappear by itself in next 2 to 3 days or by end of the week, and it doesn't require any treatment. But if you don't know that this is a physiological condition, we may think it as a pathological condition. We may start thinking about the cause, and we can start something, some ointment, some antibiotic or so. So these are the things which are very common. Some few physiological things which looks pathological, but exactly they are not pathological, they are physiological, okay. Again, in this picture also you can see there are small papules, white color, isn't it? Many are there over the face. And if you can give what is the condition in your chat box, you can write it. So okay. So if you know, this is a very similar but very common condition called milia, and this is yellowish white spots on the nose and face in particularly over the face we can see, and it is due to retention of sebum. Okay, it's so it's not at all a pathological conditions, and it also resolves spontaneously by itself. So there are many things like absent pulse, like your Mongolian spot that we call. So many things are there in the newborn which you may think that these are pathological, need treatment, but actually they are not. Okay. So they are all physiological conditions. They resolve by itself. Okay. They all resolve by themselves. So we need to know those conditions. Like another condition, what do you think? What is this condition is? Here are some red spots. You can write on your in your chat box. So if you see this is hemorrhage, basically, isn't it? This looks like hemorrhage, and exactly this is subconjunctival hemorrhage. And during the delivery process, these are seen in many term neonates. And this is also not pathological, and we should not give any treatment because it does not cause any damage, any cosmetic or any pathological damage to the newborn baby. So, uh, these are few conditions where you can you should know what are the physiological conditions. Even though looking pathological, they don't require any treatment, they resolve by themselves. Okay, so suppose you are taking a postnatal round and you find a baby having temperature of 36 degrees Celsius, and you feel 36 degrees Celsius. Normal temperature, we know it is 36.5 to 37.5, isn't it? So this baby needs to be shifted to NICU or for IV fluids and for further care. Okay, cannot be treated in your postnatal ward or in a step down ward, whatever you call, what is facility available in your hospital. So what do you think? The baby requires shifting to NICU? Can write in your chat box. So when we discuss about the hypothermia part or thermoregulation, we will talk about this. Okay. So move on to today's topic, first topic, that is care of a normal newborn. So what are the learning objectives? The provide care at birth, screen babies for visible defects, and provide postnatal care for normal babies. Even though babies are normal, they require some care, isn't it? They cannot take care of themselves. So birth, this is the crucial period of transition. Transition means from extrauterine life to extrauterine life, from a parasite to self-sustained body, isn't it? Everything he was getting from mother, even food, oxygen, everything, blood circulation, through the placenta he was getting oxygen, and through that also he was getting food, everything. So now he has to sustain his life by himself. Okay. So this is a transition period. So this is to be supported. So effective care at birth is needed, and to just to help the baby to overcome this transition period smoothly. Okay. So for that anticipation of problems during this transition, we must know and we must anticipate to provide support to ensure stabilization. Okay. So normal newborn baby after delivery, they will get stabilized, but we need to support them, just to support them so that they will achieve their stabilization. So majority of the neonates do not require resuscitation, in particular active resuscitation, and can safely be transferred with mothers into postnatal ward. That you all know, and hardly less than 10% they require some kind of help, and less than 1% they require active resuscitation, what we call. Then coming to care at birth, trained healthcare worker in neonatal resuscitation should be present at the time of birth. At least one person who knows neonatal resuscitation should be present during the time of birth, or he should receive the delivery, isn't it? That you all know through your NRP guideline, at least one person should be there, even if the baby is not a high risk baby. Baby who do not need resuscitation at times of birth should be placed prone on their mother chest and abdomen in skin to skin contact. So basically, if a baby is not requiring resuscitation, so what do? We go for routine care, that is called, isn't it? So here we put the baby on mother's abdomen and chest, and we do a little bit of support, just and our aim is to initiate breastfeeding within an hour and to maintain the temperature by skin to skin contact. So skin to skin contact is to maintain the temperature, as well as this is one of the procedure which helps in initiate breastfeeding within an hour. And also it has been seen that if you start do skin to skin contact from birth, the sustained breastfeeding is very, very high. Okay. It is not to initiate breastfeeding within 1 hour, but starting breastfeeding within 1 hour helps in sustained breastfeeding. Okay, so this is an important step to keep the baby on mother's abdomen and chest. Okay, just after delivery, those who are not requiring any active resuscitation. So what I was talking about, that routine care, what is routine care? So continue skin to skin care. Okay, then cut the cord between 1 to 3 minutes. Now delayed cord clamping is the norm. So we have to follow this and at least for a minute. Okay. We can wait, and at 1 minute up to 3 minutes, we can cut the cord. By that time, and initiate breastfeeding and keep mother and baby covered and observe for breathing and color. Simple monitoring. So what is routine care? So first keep the baby on the mother's abdomen and chest for skin to skin care. Dry the baby. If there is secretion from mouth, you can just wipe it, those secretions, and then remove the wet linen, cover the mother and baby diet with one dry linen, that at 1 minute cut the cord and push the baby, put the baby between both the breast, so that a baby can identify the nipple and start suckling it. Okay, so we are just, what we are doing, we are supporting the baby to do such things so that he can maintain his your temperature, he can maintain the respiration and start feeding and nutrition by starting breastfeeding. Okay, so cord should be, after that, the cord should be kept clean, dry, and free from any application. Initially, there are so many things. This is to be applied, that is to be applied from Johnson Violet, triple dye, some antibiotics ointment. But now it has been seen that it is better to keep the cord clean and dry. Okay, no application is required. Infant should be weighed after 1 hour, and on particularly on an electric weighing scale with a calibration of 1 gram. Okay, so if it is not available in the facility, now it is available everywhere, but sometimes it may not be available, and you may have a that spring weighing scale. So those can be, but it is meant. It is ideal to calibrate them time to time, every week, at least weekly, but best is to go for it daily. Okay, so it should, those should be calibrated. So take the weight after 1 hour, give vitamin K injection, and that you all know the doses, and 1 milligram or 0.5 milligram who are less than 1,000 gram. Other things, identification, you either put a tag, those your wristbands are available with registration number, date of birth, mother's name, weight, those things you can enter into the ID band. So next, what all you need to examine at birth? There are many things to be examined. Particularly, we should actively look for the birth defects. Okay, so after your weight, length, head circumference, and all those basic parameters of the baby, we should actively look for birth defects during the birth, like head and face, for fontanelle, facial deformity, any dysmorphic features is present in the face, eyes, particularly for cataract and red eye reflex, and mouth for cleft lip and palate. And we can look for cyanosis if it is present at birth. Then upper limb, digits, palmar crease, all those things, if all 5 digits are there, or there is polydactyly, or there is syndactyly, that means fusion of the digits or absence of any digits. Okay, or presence of more digits. So these are important. Then from abdomen, if there is a enlarged, or we can palpate for liver and spleen, kidney masses. Okay, chest respiratory rate and retractions, and any sounds, chest sounds, and look for any murmur. Then pulses, you can palpate, particularly femoral pulses. Okay, these are very important, and femoral pulses would be palpated. Then you can look, you can examine for the hip, whether it is dislocated or dislocatable. So if these are the hips, any hip is dislocated or these are dislocatable, that we need to see by Barlow's and Ottolani testing, just to try to dislocate it. If it is dislocatable, then it will be dislocated, or whether it is dislocated itself. Okay. And this is the most important, that an examination of genitalia and anus, because if you must examine the genitalia. Okay, whether any disorder of sex determination, these are there, undescended testes, small penis, hypospadias, and the large clitoris, and the cleaved scrotum, like all these things you must, because this has very, very important clinical significance, and you have to be very alert, and you should actively find out what is the cause for this DST. Okay. So these things you must look for, and at the food you can look for Telipus and Equinovarus. Okay. And in a gross, you can look for pallor, sometimes due to bleeding, antepartum hemorrhage, the baby may look pale, maybe looks jaundice because of stain of amniotic fluid, or sometimes baby looks yellow if meconium stain is also there. And if there is plethora or not. Okay, pallor and plethora you can look for, and jaundice. Okay. So for birth defect, we can follow the guideline of RBSK, operational guideline, and they have given a beautiful diagram, one pager diagram to screen for birth defects. And we can use this in our labor rooms to find out any birth defect. And these are nowadays, they are reported. Okay. In our monthly statistic, we usually report the birth defects that we encountered in the last month itself. So these are sent to the central registry for birth defects and further planning for their management. So then after doing all these things, you have to communicate with the family. You have to talk to the family about the well-being of the baby, or if the baby is having any problem. We do all these things, but just to tell you in a structured format, we are having these classes so that it will you can remember it forever, because now you are a pediatrician. In your whole life you will be seeing these newborns. Okay. So the health provider must communicate the time, birth weight, gender, condition to the parents, and it must be disclosed about the gender. You must tell and show the gender of the baby to the mother if the baby is not under anesthesia. Okay, immediately you can tell and show the mother whether this child is a boy or a girl. Okay. The infant should be shown to the family with attention to the gender and the identified tag on the infant. Then coming to identification of at-risk infants. So it is because if you identify those at-risk conditions, then you can shift the baby to the level of care, ICUs, and you can take care of them. So what are those risk condition? Babies with birth weight of less than 1800. Why 1800? You must be knowing, in all our nurseries, we used to admit all the babies less than 1800 gram, and less than 34 weeks, because before 34 weeks, that feeding, respiration, and swallowing coordination doesn't, they are not in coordination. These three things, that is swallowing, and your breathing, and suckling, these are not in coordination. So you cannot give it to the mother for breastfeeding, isn't it? But in these cases, these baby are to be supervised if the baby is less than 2000 gram, because it has been seen that even the baby is 1800 gram but less than 2000, then the breastfeeding, the vigor that is required for breastfeeding is not adequate. So even if you are giving it to the mother, the baby to the mother, you have to monitor the feeding, and you have to support the feeding for the children. Okay. So babies with major congenital malformations, babies with asphyxia, those who require post resuscitation care, particularly positive pressure ventilation for more than a minute, or they are requiring chest compression or any medication. Okay. So these are basically they are shifted for post resuscitation care to your NICU. Babies with breathing difficulty, obviously you have to support the breathing. And so now to the babies who are shifted with the mother to postnatal care, what should I look for? Okay. And how frequently I should look for. So at least twice a day, and baby should be observed for cry, activity, reflexes. Reflexes, it doesn't mean that you have to elicit all neonatal reflexes. We are not nowadays, we don't go for reflexes examination in a newborn, all the newborns. Okay, cry, activity, and rooting reflex, sucking, swallowing, that we usually see. We don't elicit moros in all the newborn. Okay, for not even for screening. Okay, so adequacy of breastfeeding, maintenance of temperature, whether the baby is maintaining temperature, appearance of jaundice, then passage of urine and stool, and any danger sign if it is present. So we, in our postnatal round, we should look for all these things. Okay. So, what is the weight gain pattern? Let the things here, like the adequacy of feeding and all these things and maintenance of temperature. We'll discuss about those later. So term baby lose up to 5 to 10% by day 2, 3 of second or third days of life, and they regain this birth weight very fast by the end of the first week. But free term, they may experience a 2 to 3% weight loss. If it is more about 5 or more, then you have to think about the pathological condition why the baby is losing weight. Okay, 2 to 3% weight loss is not, it is physiological, and maximum they lose up to 10 to 15% maximum, and they regain by 3 to 5 days and regain their birth weight by 10 to 14 days. And if a baby is not regaining weight by 14 days in case of preterm, then there is some problem in calorie intake or in digestion of food or adequacy of food, all those things. Then we have to look for that. Problems in feeding. Okay. So as I was talking, now we should know whether we've given the child to the mother, and the mother, we have asked the mother to give feed. So we need to see whether the mother is giving adequate feed or not, or the baby is receiving adequate feed or not. So if a baby is taking feed adequately, then he should pass at least 6 to 8 times urine a day after 48 hours. You cannot expect a baby to pass 6 to 8 times or 4 or 5 times before 48 hours, because very rarely they pass. In first 20 or 24 hours, they may pass once or twice, like that, or may not pass. After 24 hours, they may pass. So after 48 hours, if it's passing 6 times a day, then we are happy he is getting adequate nutrition. Okay. And the weight gain, this is the objective one basically. So if weight gain pattern that we have initial weight loss and after that weight gain, and the baby is gaining 20 to 30 gram per day, then we are happy. Okay. So baby is getting adequate feeding. And after each feed, the baby is sleeping for an 1 to 1.5 hour to 2 hours. And then also the baby is having adequate milk, because sometimes you must be knowing if mother is feeding from both the breast, so only baby is getting fore milk, not the hind milk, then the baby will sleep for very less time, and again he will start crying for feed, because those were the fore milks are usually watery, those we can learn during our breastfeeding session. So comfortably, the baby is sleeping for an hour or two after feeding. Then the baby is also receiving adequate feeding. Then regarding jaundice, you all know about the Kramer scale. So by seeing the jaundice, you can say what can be the level of serum bilirubin. Just you can assess that. So, but for this, it is very, very important. The baby should be examined in a daylight. Okay. It is better to examine the jaundice in a daylight, and for twice a day. because we have already decided to visit the baby twice a day, so you evaluate for jaundice twice a day, but better in a daylight condition. And you can use your transcutaneous bilirubinometer if available. And Kramer staging, I've already told, if palm and soles are stained, that means the jaundice is very high. Okay, the baby requires some therapy for those things, or the baby is having jaundice within 24 hours, then also it is pathological in early examination. Okay. Vomiting many a times mother complains you that baby is taking out milk after his feed, so this is called regurgitation. But pathological vomiting may also occur in such newborn. We have to differentiate these things. So regurgitation due to faulty technique of feeding or because of vigorous suckling, the baby usually they used to take air in, so those air can cause regurgitation. Okay. So proper advice regarding feeding and keeping the baby little for few minutes in vertical position uh, can also help taking out the air without regurgitation. Okay. And if the baby, even after that, regurgitates a little amount and the weight gain is appropriate, the passing urine adequately, sleeping after feeding, then also we are happy. Sometimes they take little bit of more milk and they can regurgitate those extra milk. So if weight gain is adequate, we are happy. Okay. So how to differentiate? As I was talking, there may be vomiting also, or not a simple regurgitation. So persistent of vomiting, projectile vomiting, and bile stain. If the vomitus is bile stain, then we have to look for any cause in this condition. Also, if it is associated with abdominal distension or tenderness of the abdomen, when you palpate the abdomen, the baby is grimacing, then you need to find out the cause for such vomiting and abdominal distension. Okay, so these are pathological, but simple regurgitation with weight gain, active, in those are you need to give little bit of support and nothing much is to be done. So common issues in stool pattern. This is another common problem by the mothers. So most neonate passes the meconium 24 hours within 24 hours of birth. Transitional stool, it may be golden yellow sticky stool or maybe greenish in color, maybe watery like. So you need to reassure the mother that these are normal and the baby will have firm stool after 7 to 8 days. Okay. So after meconium, there may be greenish color loose stools or watery stools that may persist for 2, 3 days or 4 days. Okay. Another problem is vomiting, passing stool after each feed. This is gastrocolic refrain and it is a normal physiological phenomenon, nothing to be worried. But here, some babies in neonate, we usually talk like this once in a 7 days or 7 times a day. 7 times in a day, all are normal. Okay, so some babies they pass very infrequently in once only in 2, 3 days, 4 days. Okay, and some babies they usually pass stool after each feed. So if other things are normal, so these are not pathological, this is physiological. But if mother says mm, any other problem associated with such condition, then you need to see. Suppose the baby is not passing stool for last few days and there is abdominal distension, then and there is vomiting, then or you can see visible bowel loops in a term baby, then these are, but you can consider for pathological condition. Okay, otherwise these are physiological conditions. So excessive crying again, it's a complaint, but usually in early newborn neonatal period, this is not that common. So why a baby cries? Why a baby cries. During the first few days, actually the baby sleeps a lot. Okay. And sometimes they may have cry during the night. Baby, why the baby cry? When they are hungry or there is any discomfort, they will cry because they cannot. This is the way they can tell you or tell the mother about their problem. Okay, discomfort may be due to unpleasant sensation of a full bladder before passing the urine, painful evacuation of hard stool, or mere soiling by urine or stool, or even during passing, after passing the stool, they may cry. Okay, so you have to find out the cause of cry if baby is crying, and these are the common things for cry in a newborn baby. So the usual term nowadays for high load nurseries in particular, so you usually discharge a term baby after 48 hours if the mother is primary, otherwise after 24 hours if the baby is multi. So there are certain things you should advise at discharge. Okay. So we basically says 5 things. This is maintenance of temperature. So you must tell the baby how to keep the baby warm and maintain the temperature. Okay. So this is very, very important. Breastfeeding or nutrition. So breastfeeding for breastfeeding to continue and nothing else is to be given at least for 6 months, and after 6 months mother can start that supplementary or complementary feeding. Okay, complementary feeding. So breastfeeding or nutrition is very, very important. You must, when the mother is getting discharged, she should be convinced regarding the breastfeeding and nothing else is to be given to the baby. This is very important part which decreases the neonatal mortality to the maximum. If the babies, they are getting exclusive breastfeeding, then chances of mortality is very, very less. Okay. And this is the most important factor in preventing neonatal mortality. Then umbilical cord should be kept dry. Indirectly, this is about so prevention of infection. The two things to keep to maintain hand hygiene, or the guests, those who are coming also should observe hand hygiene when lifting the baby or taking the baby to themselves. Then and vaccination. These are also, the vaccines are also to prevent certain infections. Okay, those are preventable. And don't apply kajal or antiseptic ointment in the eyes. These are a common practice to apply kajal and to the newborn babies. So these are to be discouraged. Okay. And about the danger sign. So poor feeding, appearance of jaundice within 24 hours. This is already we have discussed. This is pathological, or staining of palm and soles. Failure to pass meconium within 24 hours or urine within 48 hours. Undue lethargy, excessive crying. Respiratory problem, any respiratory problem, it may be increase in respiratory rate or difficulty in breathing or apneic attack or looking bluish, then it's these are all danger signs. Sudden rise or fall in body temperature. If the baby looks hypothermy or there is a fever, then they should. So these danger signs, these are the signs when the mother is to be advised to take back the baby to the hospital. Okay, immediately. She should bring the baby to the hospital for a checkup immediately when these signs are there in a baby, or any sign is there in the baby. So this is how we explained at discharge about the danger sign. And these are other danger sign like bleeding from any side, persistent vomiting, diarrhea, loose stool, drooling of saliva, seizure, evidence of superficial infection such as conjunctivitis or umbilical infection or pustules, okay, or presence of oral thrush. So these are few other danger signs which may appear in a newborn, and the mother is advised to consult immediately by taking the baby back to the hospital. So, uh, uh, so before discharge, we can follow this checklist. Ideally, the infant should be discharged after 14 hours once all the criteria are fulfilled. Infant is free from any illness, has been immunized, adequacy of breastfeeding has been established, mother is free from any significant illness and confident to take care of her baby, mother has been advised regarding danger sign. Okay, so these things are to be seen before the baby is discharged, and talk to the mother about the follow-up or when to bring back the child to the hospital for routine checkup or for immunization. So for a normal newborn, usually you ask her to come back after 6 weeks, okay? And we need, in our follow-up, we need to assess the growth and development, like weight gain, head circumference, and a little bit of developmental assessment. For developmental assessment, you can follow your immunization card. It is beautifully pictorial description of the developmental assessment in newborn babies during their immunization, when they are coming for immunization. So you just go, please go and see the immunization card, and you can realize how beautifully it has been given in a pictorial form in the immunization card to assess for development. Okay, both growth and development. Early diagnosis and management of any illness, and health education to parents, like how to take care of the baby, how and whether the mother is giving breastfeeding day and night. If she is not giving in the night or the breastfeeding frequency is less, then you can teach the mother and tell her to continue breastfeeding, and both in day and night. Okay, at least 8 times a day. Now, if you have any questions, you can just put those questions in your chat box. At the end, we'll address to all those questions, queries. Okay. So don't hesitate to ask, and just write it down on your chat box, and those will be discussed at the end. Okay. Now, the most important and very common, this is very common. If you just leave the baby for an hour, without supporting or without covering or without keeping in skin to skin contact, then they may lose heat and land up in hypothermia. So thermal regulation and how to maintain the body temperature and to prevent hypothermia is an important part of normal newborn care. So what are the learning objectives in thermal regulation? It's just an introduction, mechanism of heat loss, concept of warm chain, recording temperature, and to grade hypothermia, prevention and management of hypothermia, fever management, a little bit of about fever management, and advice and discharge. Okay. So neonatal hypothermia, you all know why the babies are more prone for hypothermia, and because we are concerned because this is may lead to death. Okay, it is not a simple condition, though common but not a simple. So we should try our best to prevent hypothermia in a neonate. Okay, hypothermia can lead to hypoglycemia because most of the calories will be used to maintain the body temperature. So, as most of the calories are going for maintenance of blood temperature, so maintenance of body temperature, so hypoglycemia may occur. There may be bleeding diathesis. It may lead to severe crisis and DIC in the body and may lead to bleeding diathesis, pulmonary hemorrhage, acidosis, apnea, respiratory failure, shock, and eventually death. Okay, so hypothermia is a very serious condition. So it may end up in death also, in neonatal death. If we don't treat it early, don't detect it early, and do the proper management, it may lead to death. Why newborn are prone for hypothermia? So larger surface area, because their body surface area as per the mass it is more. Decreased thermal insulation screen, those are not that mature, so they can lose heat and through that water loss, and reduce amount of brown fat, so they cannot generate more of the calories to compensate the losses, and lack of shivering. So usually a newborn baby doesn't shiver, which prevents hypothermia. So what is the mechanism by which a newborn baby loses heat? You all know evaporation. Evaporation, the fluid that is on the skin can evaporate, and it will take away the uh, temperature, and it cools down the body. You must be knowing, if you put water on your body and stand under a fan, you feel cooler, isn't it? So it is all because of evaporation. So evaporation, it is through evaporation a newborn baby loses heat. Conduction, so from body, if it is in contact with a cold object, suppose the seat or clothes those we using are cooler, so the baby will lose heat. Okay, so contact surface should be warm always. Convection, air current, if air current is passing, then also in summer we used to use fan, and by that we feel cold. So this is the convection or air currents in which cold air replaces the warm air around the body. Okay, and radiation to the colder solid objects in vicinity or the walls. So for this, we to prevent all these process of heat loss, we usually um, in routine care we keep the baby and skin to skin contact with the mother, and in sick baby, we take them to radiant warmer or incubator. So this is a pictorial description of heat loss, radiation to cooler wall or surfaces, and conduction. It is body contact, convection, airflow, and evaporation through any any amniotic fluid that is there on the body. So immediately after birth, we dry the baby and keep on skin to skin contact, and usually cover the baby to prevent with warm linen, of course, that you all know. So use warm linen to cover the baby, so it will prevent your all the process of heat loss. So warm chain, okay, starting from warm welcome with the warm linen when you receive the baby after birth, and to prevent hypothermia even after birth. Okay, this is called warm chain. It comprises of warm delivery room. We keep delivery room around 26 to 28 degrees Celsius. Warm resuscitation, so either on the chest of the mother if routine care is required, or under the radiant warmer. Okay, immediate drying and removal of wet linen. You all know, you know about your NRP. It gives emphasis in drying and removal of the wet linen, then skin to skin contact. Breastfeeding, this is even though doesn't look directly reducing the your heat loss, but it provides energy which is required to maintain the body temperature. Okay, so it is though like in like other parameters like a clothing, postpone bathing, weighing, rooming in, worm transportation, these are directly preventing hypothermia, but breastfeeding, this is very important. Even though not directly contributing, this is a very important thing to prevent hypothermia by providing calories. So assessment of hypothermia. So what is hypothermia? The normal temperature is 36.5 to 37.5 degrees Celsius. Okay. And temperature below, any temperature below 36.5 degrees Celsius, we call it hypothermia. So you can grade it also. Cold stress, particularly from 37 6 to 36.4, and moderate hypothermia 35.9 to 32, and severe hypothermia if it is less than 32. Okay. For management point of view, you will see a different grade of hypothermia that we'll discuss when we come to management. Okay. So this is simple cold state, moderate, and severe hypothermia. So temperature recording, axillary, it is as good as rectal. So no need to put rectal thermometer all the time. You can use a axillary thermometer. The process should be optimal. So to keep the thermometer vertical, and the uh, thermometer end should be touching the axillary roof. It is not put horizontally, it is put vertically. Okay. And you can use a digital thermometer. And skin temperature by thermistor probe that you must have seen in your radiant warmers. So this can be, temperature can be monitored through thermistor probe also. If at home mother doesn't have a thermometer, there is no probe, of course. So how can she know whether the baby is having normal temperature or the baby is hypothermic? So if warm and pink feet, that means the baby is warm. If feet are warm and the feet are looking pink, then it is almost sure that the baby is having a normal temperature. If feet, those are cold, but the core body or the abdominal area, chest is warm, then the baby has started or is under cold stress. Now periphery has started getting cold. Okay, even though the core area is still warm. So this is called cold stress that we take from 36 degree to 36.4 degrees Celsius. Okay. And both the feet and abdomen are cold. That means the baby is having significant hypothermia that we call moderate to severe hypothermia. Clear? So, uh, uh, this is how you can assess the temperature by touching. Okay. And this is to be told to the mother when at discharge. So clinical signs and symptoms. So these are all non-specific. These signs you can see in sepsis, in hypothermia, in hypoglycemia. Okay. So the signs and symptoms are very non-specific in newborn. They will be lethargic, they will be irritable. There may be poor feeding, poor weight gain. If the baby is continuously on cold stress, then they will not gain weight. You must be you will think we are giving breastfeeding, everything is fine, but the baby is not gaining weight because the baby is not adequately covered up. So the temperature maintenance in a thermoneutral zone is very, very important. Otherwise, if other symptoms are not there, then also the baby will not gain appropriate there won't be any appropriate weight gain. So be vigilant for that. Okay. There may be breathing difficulty or severe hypothermia may manifest with hypoglycemia. We have already discussed because the calorie will be spent to maintain the temperature. It may lead to sclerema, as you see in sepsis commonly. It may lead to DIC and bleeding. Okay. So, prevention of hypothermia at birth by giving routine care or skin to skin contact. If the baby is not requiring any active resuscitation, that will prevent hypothermia as well as it will establish breastfeeding. Okay. And during this routine care, you have to cover both the mother and baby with dry linen. Okay. And the baby should be put on the bare chest of the mother, not with a layer of clothes in between mother and the baby. So over the bare chest, okay? And both should be covered with one cloth or two clothes, whatever is required according to the environmental temperature. And start breastfeeding as early as possible, not 1 hour, as early as possible, maybe in 5 minutes. Okay. So start breastfeeding as early as possible. Second is KMC. This is one of the best method usually used in preterm baby. And if hypothermia is there, then one can, in the case of term baby also, you can use these to prevent hypothermia. So better thermal protection, increase breast milk. There are so many benefits, many benefits. Increase milk production, increase exclusive breastfeeding rate, reducing respiratory tract or nosocomial infection because the baby is in a secluded position, no complication, less of pricking, less of injection, less of IV cannulation. So it reduces the sepsis also. Improves weight gain because thermoneutral zone, so baby will gain weight better. Okay. Improve emotional bonding between mother and child because they are not separated, they are in together, so mother feels very happy and emotionally the love for the baby develops, and the bonding develops between mother and child. It reduces the hospital stay as we growth is faster, less of infection, less of other problems, so discharge will be faster. So reduce the risk of mortality. It reduces near about 40% mortality if you give KMC. Okay. So improves growth and optimum long-term neurodevelopment. So many benefits you can see with KMC. Management of mild hypothermia. Here you can see it is 35.5. So for management, we have graded this like this, 30.55 to 36.4. So here you can do KMC. Okay, that is the best method or preferred method to regain the temperature or to maintain the normal temperature in normothermic zone. So if KMC is not practical, warm the room between 26 to 28 degrees Celsius as we maintain the labor room temperature using radiant heater or heating devices. But KMC is not practical, is something unusual. It is very, very unusual. Anyone can give KMC. If mother is sick, then other person can also give KMC. So it is actually not impractical. Okay. So very rarely you may find sometimes it is not practical. Covered adequately and replace the cold clothes with warm clothes. Continue breastfeeding. Monitor auxiliary temperature every half an hour till it reaches 35 degrees Celsius. So every half an hour, you'll have to monitor the temperature till it reaches the normal temperature, lower normal temperature. Then hourly for next 4 hours. Okay, then 2 hourly for next 12 hours and thereafter 3 hourly. So this is how you manage the mild hypothermia. If the baby remains hypothermic after even 1 hour after supervised KMC, or if any danger sign appears, then think about sepsis and other causes. Okay, and you can manage the baby in NICU. So for mild hypothermia, simple KMC after 1 hour, just revise, just review and see whether it is now hypothermia is still persisting. If persisting, then try to find out other causes, particularly if any danger sign is present. So this is wrapping the baby. Here you can see they are wrapped with clothes, with caps also in winters with woolen clothes. As per the environmental temperature, you have to give an extra layer for term baby and 2 layers extra for preterm babies. Okay. So here you can see how to wrap the baby. So this is a cloth. So this one corner is folded like this. Then you put the head on the folded area. Then from one side, you have to fold it. Then from leg side. Okay. From one side, it is from right side. Suppose you have folded the cloth. Then next is the leg side. And lastly, the left from the left. You can do it from left first, then leg, then right. It is, but not like left, right, then leg. Okay. So leg side should be folded in between so that the tucking and good cover can happen. Okay. So this is how you wrap the baby with cloth. So now coming to management of significant hypothermia. Here you can see we are not using moderate or severe hypothermia, but below 35.5, 35 0.5 degrees Celsius, it is called a significant hypothermia. So here remove cold clothes, replace with warm clothes, place under radiant warmer with clothes including caps, socks and mittens. Okay. Monitor temperature and other vitals every 15 to 30 minutes because this is a very serious condition. And as we know, it may lead to respiratory problem, it may lead to bleeding problem, and it may lead to death also. So continue breastfeeding if the baby is able to take feed, and if it is not possible, give express breast milk through paladi or through a spoon, or you can give gavas feed. If baby is not tolerating feed, then we can start IV fluid. So immediately after this, we should not start IV fluid. We can try with the express breast milk. Okay. If perfusion is poor, then you have to manage as per the guideline of shock, the 10 ml of normal saline slowly over an hour you can give, or then injection of vitamin K to prevent bleeding, provide oxygen and monitor saturation between 90 to 95. If the baby is not maintaining saturation, just provide oxygen, okay? And you have to have a saturation between 91 to 95%. So, if the baby is severely hypothermic, like less than 32, you can rapidly rewarm the baby to 34 degrees Celsius, then gradually rewarm, that is 0.5 degrees Celsius in every half an hour. So that is also a protocol to manage severe hypothermia. So additional steps, continue breastfeeding. In every management of hypothermia, one point is coming, continue breastfeeding, because this is the thing which provides the baby with calorie, and that calorie is required to maintain the temperature. Okay, so don't forget to maintain the nutrition. If baby is not able to, then this. Okay. So now coming to fever. Fever, as we all know, the normal temperature is between 36.5 to 37.5. So any temperature above 37.5 is fever. So common causes are basically environment is too hot during summer. Okay. And baby is over dressed, means multiple layers are used just to prevent hypothermia, but the baby is now in hyperthermia. Okay. Keeping the newborn too close to a heater, leaving the baby under heating devices unattended, or sometimes or rarely in sepsis like UTI, meningitis, malaria, congenital malaria, or in sometimes in case of abscess, you may have fever, but hypothermia is more common than hyperthermia. But so in these conditions, what I told just before, they may cause hyperthermia. Okay. Move the baby into colder environment and use loose, light clothes. If it is overwrapped, then you remove few layers. Okay. Remove the baby from the heat source. If the temperature is above 39, sponging with tepid water. This is important. Now, if baby is above 39, then you have to cool down him faster by use sponging tepid water. Give frequent breastfeeding. Only if the baby cannot breastfeed, give EBM with pottery spoon or gavage feeding. If baby does not tolerate feed, then start IV fluid. Okay. Measure the temperature hourly till it becomes normal. So work up for one hyperthermic baby for infection if there is undue lethargy, excessive cry, seizures, poor feeding, persistent vomiting, respiratory distress, apneic attacks, cyanosis, bleeding from any side, pustules or umbilical sepsis. Okay. If these are there, then you can suspect, you have to suspect sepsis, and you have to uh, investigate the baby. If these are not there, then and you have seen that baby was overclothed, or the environment temperature is too high, or baby was to one heating device unattended, then you can consider is environmental or hyperthermia due to environmental temperature. So discharge advice and follow up for this. At home, ensure that the baby is adequately covered to prevent hypothermia, continuous breastfeeding day and night. Okay, always emphasis the mother for night feeding also. Extra care for low birth weight babies, continuous skin to skin care, that is KMC. Rooming it always should be with mother and room should be warm. Okay. Clothing 2 to 3 layers of clothes along with the blanket to cover the baby, and hand, foot, the hands, feet, and head should be covered. Okay. So this is all about your hypothermia and hyperthermia, and previously we discussed about normal newborn. So I hope you have put some questions in the chat box. Dr. Tapas, can you see the chat box? And I can. Dr. Tapas, are you there? Hello. Hello, Pratima.
Hello, sir.
So I am closing the slides. If any question in the chat box.
Okay, sir. We are checking.
So I am on sharing the screen now. Okay.
Okay, sir. Not an issue.
How to do that?
No, sir. We haven't received anything.
So, okay. So any question there in the chat box?
No, sir. We haven't received anything.
Chat. There is nothing in the chat box, I think. So, everything is understood. I don't know. No questions, I think. I'm not seeing.
No, sir. We just have received comments. Like no and some answers, but there's no question.
Okay. There is no question from the participants. Okay. So over to Pratima then. There is no question.
Sir, actually, Pratima ma'am is not here.
Acha, she is not there. And if she is not there and no question, Tapas is there. Tapas, are you there?
No, sir. Sir is also not there. But sir, we have received one question. I'm just pasting it in the chat box.
I'm not seeing any question actually. I don't know.
Sir, I have sent it in the chat box.
Yeah, one is there. I can see. See. So, Dr. Madhu, how does KMC decrease risk of respiratory and nosocomial infection? Okay, it's a good question, Dr. Madhu. So, how it prevents KMC? So, basically, what is KMC? Basically, KMC is an environment which mimics very, very closely to your intrauterine environment. Okay. So, how does it prevent respiratory problems, risks for respiratory problem that you are asking? Because what happens as the baby is on the chest, okay, with respiration, the baby is having movement, okay. With movement of the chest of the mother, there is some movements. So, such movements actually it prevents apnea. Apnea, other condition, what are the other causes of apnea? Like hypothermia. That causes apnea. As you know, hypothermia is prevented by KMC. There is a movement of chest continuously because of breathing of the mother. And the baby is getting in, KMC, they get adequate milk also. The mother secretes adequate milk, and through, if the baby is a preterm, we give those milk through gavas feeding, then baby is getting adequate calorie. And the respiratory distress part, as you know, there is one of the cause for respiratory distress in later part of neonatal period, day 2, day 3, day 4 is due to infection. And KMC, as it keeps the baby close to mother and it is secluded from the surrounding environment, the chances of nosocomial infection is less. As the baby has less of the problems like hypothermia, hypoglycemia, and respiratory problem or apnea, so chances of needle prick is less. Okay. So all these, they prevent your infection in total. And the respiratory movement of the chest, it prevents apnea, and the pneumonia is prevented by prevention of infection, nosocomial infection. Okay.
Sir, I'm checking.
Any more questions?
Yes, sir, I'm checking, sir. No, sir. This is the only question that we have received, sir.
So then can we stop here?
Yes, sir.
Okay.
Okay, sir. So now with all your permission, sir, thank you so very much, sir. And with all your permission, I'm closing the session here for today.
Thanks,
And
Momita. Thanks.
thank you so much, sir. Good night. সবাইকে মিউট করে দিই